Hello, I'm Dr. Walter Koroshetz, and this is a pre-recorded director's message for the September 2020 NINDS Council meeting. I want to start off by mentioning the new leadership changes occurring at NIH. Dr. Michael Chang from Oregon Health and Science University has been appointed the new National Eye Institute Director. Dr. Rena D'Souza, the professor at University of Utah in Dentistry and Neurobiology, has been appointed the Director of the National Institute of Dental and Craniofacial Research, and Dr. Lindsay A. Criswell, Vice Chancellor of Research at University of California, San Francisco, and a rheumatologist, has been appointed Director of the National Institute of Arthritis and Musculoskeletal and Skin Diseases. As usual, I like to start off the director's message with mention of the NINDS and NIH budget. As you all know, we have benefit from sustained increases from 2016 till the present. However, the budget for the future years is uncertain. We are currently operating under a continued resolution, and we have three budget pictures to think about. One is the president's budget, the other is the Senate budget, and the third is the House mark. Conservatively, we feel with a continued resolution, we can probably manage with a 14% pay line, and we'll talk about what that means later. In terms of the 2020 budget, you can see here in the pie graph where the funds have been distributed. The largest percentage to extramural investigator-initiated grants and grants that come in to particular RFAs. There's also a large amount of funding that we have for the BRAIN initiative that comes to NINDS, and the HEAL initiative being the Helping to End Addiction Long-Term initiative. And both those types of funds are used to support multiple institutes and are not therefore within the direct purview of NINDS. The intramural budget is here. The budget RMS for management of the Institute is seen as 3.4%, and then congressionally mandated small business grants amount to about $67 million of 2020 funds. We also manage with the National Institute of Aging about $212 million of funds for the National Alzheimer Plan, and this is for research to reduce the burden of illness due to dementia, particularly in the NINDS case, vascular contribution to dementia, frontotemporal dementia, and dementia due to Lewy bodies, either Lewy body dementia or the dementia of Parkinson's disease. And so you can see how that was distributed as well in 2020 in the pie graph to the right. Here you can see plotted over years our success rate for those folks applying to NINDS for grants. And it hovers between about 19 and 21% chance of obtaining a grant success during a given year. And this is basically related to the fact that we pay our grants up to a particular pay line until we run out of funds, and that's what determines the success rate by and large. The percentile pay line is that pay line I just mentioned, and currently the best scoring grants up to the 16th percentile have been funded in 2020. As mentioned, with a continued resolution going forward, we would have to cut this down to about 14 percentile. We'll explain a little bit about that later. This is where the funds were distributed. There were some COVID supplements seen here at the top. We have an R35 program, which funds excellent research programs out to 8 years. We have requests for applications for particular topics seen in green. We have select pay, which we'll talk about. These are grants paid above the pay line. One of those categories is early stage investigators, those within 10 years of their final terminal degree are paid up to the 25 percentile. We had a very small amount going to new clinical trials in 2020. We have a translational program, which is quite sophisticated to bring discovery to therapies through the process of getting FDA approval for going into patients. And then in 2020, we also funded our 21 grants, which are 2-year grants, and we funded both of those years out of 2020 funds. And the reason is because with the potential for a continuing resolution throughout 2021, as you can see, the amount of funds seen in blue that are available for new investigator-initiated grants has dropped, which drives us to reduce the pay line to the 14th percentile, and paying both years of the R21 and 2020 helps us to at least achieve that 14th percentile. I want to just review for folks that the funding decisions at NIH are made to advance our mission, and that is to further the fundamental understanding of the nervous system and to use that knowledge to reduce the burden of neurological disorders. And to achieve this mission, we're constantly surveying the scientific landscape and analyzing our portfolio to ensure the holistic health of the science effort here at NINDS. Most of our competing budget supports the ingenuity of the research enterprise and funds investigator initiation research within an annual established pay line. In addition, we also design programs and funding opportunities for particular reasons. So to capitalize on, say, scientific opportunities, such as the BRAIN initiative that was announced by the president, to fill gaps, such as a basic science RFA, when we realized that the percent of applications coming in for basic neuroscience that's so important for the fundamental understanding of the nervous system, that they were falling. And so we started an RFA to fill this gap. Also to rise to meet public health challenges, such as the health challenges of dementia or chronic pain and opioid abuse or COVID-19. And then importantly, looking to the future, it's critically important that we train and sustain the biomedical workforce, so funds are appropriated to really innovative training programs. Now, we do fund some grants above the pay line, and we call that select pay. And we do that to ensure the health of the neuroscience research community as a whole. The study sections, which we rely on heavily to give us scores and percentiles, are a tremendous asset to NIH, but in some instances, to kind of fill in the in-between, the gaps, we have funded grants above the pay line called select pay. Usually, these are all within 10 points of the pay line, and so in fact, they're excellent science, and in multiple different analyses, it's very difficult to see any diminished value within 10 points of a pay line. The grants that are just below the pay line and get paid versus those that just missed and don't get paid are really in the same, or usually in the same value category. And we present these applications based on their contributions to the holistic health of the NINDS science community and their ability to fill scientific gaps. So some examples of these are Bridge Awards. These are one-year awards to investigators who do not have other lab support. And we do this to prevent the loss of human capital and infrastructure to give a chance for these investigators to come back with a more competitive grant. And this has been quite successful in achieving that goal. I mentioned the early stage investigators. It's important that we equalize their success rates with those of established investigators to ensure an ongoing pool of really talented people coming into the NINDS portfolio. We also fund grants that bring diverse perspectives to excellent science, whether it's tools, skills, or increased diversity to the workforce, which we're going to be talking about in the second part of this director's message. And then also there are some grants that are high risk, potentially leading to the fact that their scores just miss being included in the pay line, but they have such potentially high impact that we think that it's important to reach for some of these and fund them. I want to shift now to COVID. So there have been certainly pressure on the budget due to COVID, although I think we've only seen the beginning of this. This is a pie chart showing the funding that's gone out to COVID-related research or COVID-related activities, such as in the intramural program to purchase PPEs so that research can start going on in the laboratory safely. In addition, we funded impact supplements to trainees who were caught in the transition due to COVID and couldn't progress from one stage of their training to a faculty position or to the next stage of their training. And then we've also awarded COVID-19 research supplements to help us understand the neurologic manifestations of COVID. And those budget numbers are seen here in thousands. Note that we still have a research supplement call that's still active, and that is urgent competitive revisions for research on the biological effects of COVID-19 on the nervous system. NIH as a whole is also working very hard to develop new therapies to prevent and treat COVID-19 patients. NIH supports multiple phase 3 clinical trials investigating vaccines. NIH is supporting controlled clinical trials for various other treatments, including trials to test neutralizing monoclonal antibodies for infection, immune modulators to depress the cytokine storm that occurs in COVID, and anticoagulants and antiplatelet treatments to prevent thrombosis, a major complication of SARS-CoV-2 infection. There are also large efforts going on in NIH to improve testing for COVID. And I just want to point out RAD-X up is particularly targeted at reducing those factors associated with disparities in COVID-19 morbidity and mortality for underserved and vulnerable populations. The neurologic complications of COVID have been reported. They are still under investigation in terms of the numbers, but as we mentioned, COVID-19 causes blood clots to form throughout the body, and that certainly has led to strokes. COVID-19 infections are linked to multi-system inflammatory syndrome in children, which can also cause stroke and inflammation. Currently, there is absence of clear evidence that the infection involves the brain itself. So far, no evidence that clear evidence that the virus is infecting brain cells. But however, following recovery from COVID-19, there have been a number of parainfectious events that have occurred, and these are commonly seen or not so commonly seen after severe inflammatory conditions or infections. These include acute necrotizing hemorrhagic encephalopathy, acute disseminating encephalomyelitis, and anti-NMDA receptor encephalitis, transverse myelitis, and Guillain-Barré syndrome. We have a database that's soon to be ready for reporting that will collect neurologic complications of COVID on a wide basis. There's also, as you can see here in the graph on the right, emergence of post-COVID syndrome with a high rate of reported fatigue and raises potential for long-term disability. The graph on the right shows the symptoms that occurred to 143 persons in Italy during COVID, and then at their follow-up, and the average time of follow-up was about 2 months. NINDS, as mentioned before, has funded 5 supplements to collect clinical imaging and other data on the neurologic aspects of COVID-19, so we'll be collecting data here in the US as well. The impact of COVID-19 on research has been profound. COVID-19 research has been prioritized over nearly all others, as would be expected. Clinical trial enrollments have been disrupted. The labs were closed and are just opening up. In many cases, there were loss of animal colonies during COVID. Parents with young children appear to have been disproportionately affected, with a worrying report of a decline in women authors on blueprints. And this is related to the investigators, of course. And this concerns that the investigators earlier in their career might be more affected. We have done an early analysis of the applications coming in, and we have not seen any dip in applications in the post-COVID period. So if you look at January to April, and May, August. In 2017, 18, 19, and 20. If anything, there was more applications coming in 2020 in the post-COVID period than there were in previous years. We are keeping a careful watch at the trainee applications. There was a slight dip we saw in the May, August 2020, but the numbers are small. And as you can see, overall 2020 numbers are actually up compared to previous years. We have at NIH made accommodations for lost research time. There's lots of different flexibilities that have been published on this FAQ seen here at the bottom of the slide. And also NINDS has been funding extensions of our postdocs, F32s, K99s, K22s, when they're caught in transition and can't move on to the next phase because of COVID. Now we're going to break for a discussion of these issues, and part 2 of the director's message will follow in a separate videocast. Thank you.
All right, so the second part I titled Combating Racism and Promoting Equity at NINDS. And if you've been reading the papers, you know why we're talking about this. But there's also things that we're going to talk about that are really particular to NINDS. So as again, we've got to be focused on our mission. Everything we do has to go towards achieving our mission, which is to seek fundamental knowledge about the brain and nervous system and use that knowledge to reduce the burden of neurological disease, but for everybody, for all people. And that means, you know, people from all the different racial ethnic groups that make up our country. So in thinking about this, I'm going to talk about 3 different areas in terms of what we can do. What we can do as an employer, what we can do as a funding granting agency, and what we can do to support research that decreases the burden of neurological disorders in Black Americans and other underserved populations. And so we worked multiple people in the Office of Director, and we put out this director's message in June if people are interested. So the first thing we do is we listen. So we've had a town hall meeting. I think we talked about that before. Some of our folks have taken part in events like Marguerite Matthews, the Society for Neuroscience, Black Lives Matter and Neuroscience group, the National Academy of Medicine group that Michelle worked with, and listening to, you know, the kind of stories which are hurtful and sad actually to hear about in this age, but important to hear about because they're going to direct what we do. So let's talk about NINDS staff first. So as NINDS is an employer, and so this is the breakdown of the government employees in NINDS. And as you can see, 65% are white, but 13% are Black or African American, which is pretty close to the 14% in the U.S. Asians are overrepresented at 18, and our biggest problem is we have very few Hispanic Americans working at NINDS, and also, as you imagine, American Indian, Alaskan natives or Native Hawaiian or Pacific Islanders. But if you had to, you know, put your eye on a target, it would be improving the Hispanic Americans in the NINDS staff as a goal to go forward. Remember, this is all staff. Now, if you look at, say, intramural, and this is the principal investigators, this is not NINDS, I want to emphasize that. This is all of NIH data. And there you can see that the number of, say, Black or African Americans in the different positions, which we could go through all of them, but it would drive you nuts. It can stretch from 0 African Americans to a top of 5%. If you look at Hispanics, it could go from 0 to 8%. So these numbers are really not anything close to what you would like. And so clearly in the science part of intramural, we have to do a better job. And that stands to NINDS as well as the rest of NIH. There is a group at NIH who came with a letter addressed to Dr. Collins. It's called 8 Changes for Racial Inequity at the NIH from the NIH community. And these are the things that they were pushing for. Advocating, I mean, really kind of making it obvious that really you should do this. So publicly and explicitly identifying diversity, inclusion, and anti-racism as top NIH priorities. Track and publicly report workforce diversity data. Improve representation of Black and Indigenous and Latinx staff at NIH. Implement an annual workplace climate survey that includes questions specifically addressing the experience of perceived race-based discrimination, which unfortunately is real. Develop required anti-racism and anti-discrimination training for all NIH employees. Require and incentivize leadership to be active participants in NIH diversity initiatives. Implement a wage equity plan and rebrand the NIH's current harassment doesn't work here initiative as racism, discrimination, and harassment don't work here, and expand course offerings to do so. So these came to Dr. Collins. Dr. Collins met with the group, and across NIH now, there's a big effort to not just respond and act on these recommendations, but to move even further than that. And we'll talk about a little bit about that. So what can NINDS do as an employer? Well, we can certainly have greater outreach to those with diverse backgrounds as we hire into our extramural and office of the director. We can certainly have greater outreach in recruiting young scientists from diverse backgrounds to the intramural program. And in fact, the intramural program does have a science scholars program that funds intramural tenure tracks to come into the NINDS. And these are independent research scientists who have a commitment to building a diverse intramural research program. We can scale up the training programs that we have in intramural for underrepresented groups. This would be postdocs, postbacks. We also have a really amazing summer program that has a strong, diverse makeup, and a year-long, really decade-long project that Rita Devine runs that outreaches to Native Americans, both bringing them here to NINDS and bringing neuroscience out to the reservations. And importantly, we have to create a fertile field. If we're trying to seed greater diversity and it falls on unfertile ground, nothing's going to grow, is the idea. But if we can make sure that the culture is inclusive and people feel welcome, I think that goes a long way. And Maureen Gormley, who's Associate Director for Management at NINDS, has been working for a couple of months now, and COVID really kind of set us back. What we want to do is to set up a program called Proactive. It's a workplace support network that organizes and trains peer advisors to provide support, guidance, and resource information to coworkers. What we've learned in the past is when something bad happens, no one wants to talk about it. Particularly at NIH was this hierarchy, and so nothing happens because nobody knows, no one says anything. We feel that we have a cohort of people that people can trust to talk to, that they can help folks negotiate through their troubles, and then also be the ears for the Institute, but keeping privacy. We don't want to know anybody's names, but to really know where our weak spots are so that we can do better in the future. So these are the kind of things we're thinking about. Now, NINDS is a granting agency, and I'm sure a lot of people in this panel have been thinking about this for a while, and these are kind of very depressing numbers. So if you look at we're going to look at the funding rates and the application rates. So if you look at 2013 and 2018, although there's an increase in the applications from African Americans and Blacks, this is not even close to what you need to be. So we really need to find out, how do we get more people into the fold at the spot where they're submitting R01 grants. And there's a lot of factors that come into that, and we have to kind of look and kind of break it down and work on each of the factors to kind of increase the pool. And similarly for Hispanic Americans, it's really not much better, and there again we need greater efforts. Now, if you look at the funding rates, you can see there's also disparities in the funding rates between, say, African Americans and whites, and even a little bit between Hispanics and whites, but not as much. And that disparity is, proportionately improved, but it's still, over 10.8% gap between the Black and white funding rates was 9.6 in 2013, So the absolute difference is not really changing very much. So that's really I mean, if you have to look at the facts, I think these are the things that you can't get away from and have to work on. And across NIH, only 2% of the R01 awards go to PIs who are African American or Blacks. Now, NINDS is no better. We're probably worse. We think to R01s, only 1% go to Black African American. So you could say, well, what's the right ratio? It's probably the population in the U.S., but whatever, it's definitely not 1%. So, I think, trying to move this needle is something that I think everybody can get behind. And the Hispanic is 3%, but that's still terrible. Their population proportion is about 18%. And so this is way, way, way below what it should be. So we have our work cut out for us. And then it's even more daunting when you look at the data of African American PIs and what are the popular areas in which they apply. So this is data that has been posted by Mike Lauer on his website, which I encourage people to read, because we're not going to go into all the details, but just to make the point that, so they tried to look at the topics that are popular in more than 50% of the African American applications. And so the most popular went to, no surprise, the National Institute for Minority and Health Disparities, Nursing Research, Fogarty Institute, Child Health and Development, Drug Abuse, Alcohol Abuse, Aging. And then there's the rest of us down here at the lower quartile, and NINDS is probably looks the worst in this context. So we need to really understand how to attract more people from these communities into neuroscience and the neuroscience underlying neurological disorders. And we have been working really hard at this. Michelle Jones-London has toiled in this field for decades and put together incredibly innovative programs, very successful programs, particularly for bringing people, say, out of the undergraduate programs, for say the Endure program that Gina knows, to go into neuroscience and PhD programs. But we have to empower this group that we have here, who's really talented, to even do more. Now, why is it important? I don't think we really have to talk too much about this to this group, but I think this is a public meeting, so I think we should go through this. That to make the statement that NIH grants go to institutions and not individuals. So we are advancing our mission. Have to keep our focus on the mission. We can't make grant funding decisions on the basis of an applicant's race or ethnicity. It's got to be all about the science. But the funding is coming from the U.S. taxpayer, and it should reflect the needs of all segments of the population. So you certainly can't ignore the facts that we presented in the previous slides. And we do think, and I think there's a lot of evidence for this, that a diverse set of perspectives and approaches is an asset to science. I mean, you just have to think about where our science is right now and realize that if it wasn't for the international makeup of our science, we would be, probably decades behind where we are now. But we are bereft of the kind of inputs that should come from our Hispanic, African American, Native American populations, and from NINDS as well, from women. So I think those are the strong cases to be made. And the additional one is that, in terms of improving the burden of illness, each of these populations we're talking about suffer from tragic disparities, whether it's disorders that affect predominantly women or are worse, say, like COVID in African American or Hispanic populations, that we have to solve these health problems. And I think it's kind of nutty to think that you're going to do really great solving them if you don't have anybody from these populations helping you solve the problems. We don't want to say you have to solve the problem because you're from this group. That's not the thing. We don't want to put this on anybody's backs. It belongs on everybody's backs, independent of what race or ethnicity you are. but to have input from these racial and ethnic groups, the socioeconomic disadvantaged people. If you're trying to solve their problems, you really need input that's relevant. So, okay, so what can we do? Well, we can rethink and kind of scale up what Michelle's been doing in terms of the training and the pipeline, but realize that there's a lot of things that are going on in that pipeline before you get to submitting an R01. So, and there are certain things that we have influence over, some things we don't have influence over, but we can, I think, make a difference. I think we could probably make a bigger difference if we start early, and give science opportunities to people who are growing up in areas where they're not available. Certainly, all of us have a story of how we got into science. Everybody's an individual. They're different, but I bet you they all have this common thing that, you know, some hook got me when I was in high school or early in college, and that's why I am where I did what I did as a career. And so to kind of incentivize, make sure that that's available to everybody, is, I think, something that we can do on the education side, dropping down into high schools, colleges, but realize that the pipeline solutions are not going to solve all the challenges. We have to always look for bias on, on every level, to see what we can do to reduce bias. But I don't think that either of these things, well, I know that either of these things, even if you did your best job, it's not going to, the solutions are going to be slow in coming, meaning like 20 years, 30 years. So are there ways to accelerate? So one idea, and it's not my idea, but I think it's a cogent one, is that we can accelerate the health of science at the faculty level by doing things that kind of break the ice. And I think, a big problem is just getting the ball rolling. So we have a neurobiology program that's got one person who's an African American. I'm not sure that, the college students who come through are going to see, well, I don't really see this for me because I don't see anybody who looks like me. But, potentially if there were 3 or 4 people who will come from these populations, that would be a magnet, perhaps, that would help even the trainee side, as well as, really make a big difference in the culture of the department that they go into. So we have an NINDS and through the BRAIN Initiative programs that are what we call postdoc to faculty awards that actually, hit right at the target, which is getting people into faculty positions. Because that's the target. Those are the people who submit the R01s. You don't have a faculty position, you don't submit an R01. You have a faculty position, you're supposed to submit an R01. So the other one is the NIH First program, which is coming out of the Common Fund, and Michelle and I kind of worked on this even before it went to Common Fund. But we're hopeful that will do something. It's a program that's going to fund what we call cohort hiring. So if you have a neuroscience program, it'll have funds, startup funds, not complete startup funds, but pretty good startup funds to hire people as a cohort. So it's not just one person who's African American in the department. It could be 2 or 3, or an African American, Hispanic, and a white woman. It could be a mix, but the hope is that they would be successful because they come in as a group and they bind together and they succeed as a group. So that's the idea behind the first program. And then I mentioned this earlier, that select pay is the other thing that and you'll see that today, that we look at the applications, particularly those within 10 points of the pay line, and look for grants that bring diverse perspectives to the science, and propose them to the Council for select pay. And if you look at any analysis that's ever been done of the grants that just missed the pay line versus the grants of people who just made the pay line, and you look at the final outcomes, you rarely see any difference. So we depend on the peer review system, but we know, there's nothing magical about the 16th percentile versus the 15th or the 17th, or the 20th versus the 15th. And so we feel that this is a way of improving the value of the science going forward, because we're only funding really good science if we go 10 points from the pay line. And then we need to really develop and track our metrics so that it's obvious to everyone how we're doing, especially the council, and so that we know, where things are successful, where they're failing, where we need to put more efforts. I would say that NIH leadership across the Institute, Dr. Collins' office, major discussions going on, lots of action items being discussed, numerous committees. NIH is really good at forming committees, but this time they're going to do something, I'm absolutely positive, in this space. So look forward to that coming forward. And then finally, I'm going to talk about health disparities as the other thing that I think is within our responsibility to make a difference in disadvantaged communities. So we're really committed to this, and Richard Benson, we're so happy Rich is here now, directing the Office of Global Health and Health Disparities. And as you know, the strategic planning going on, and appreciate the input of the council into that. And, there's lots of examples of disparities. The one that we know the most about, because we've invested considerable epidemiological research into this fact that African Americans are disproportionately affected by stroke, particularly in the Southeast United States. And the data from the REGARD study basically says that only 40% of the disparity is attributable to the prevalence of traditional risk factors, particularly hypertension. 60%, we still don't understand what they are, why African Americans have higher mortality rates due to stroke. There's still 60% of it is unexplained, and that's a real scientific question to get at the bottom of. So as you know, we have the work group that Karen and Ed are leading of the council. We have a group inside NINDS of our program staff who are working in a work group, and then there's a trans NIH committee also looking at health disparities and how we can do better across the NIH. We had RFIs, so we're collecting information from multiple stakeholders. And importantly, there's a September 23-24 workshop to discuss areas of priority and potential interventions to address the most impactful areas to achieve health equity. And I hope that we can get really good input, and please join if you can. And, this is really to help Richard kind of formulate a strategic plan. And I've been pushing at each of these levels to avoid just doing research. I think I'm not talking exclusively, but just doing research to collect data. We've been doing that for years. We're really short on research that intervenes to actually make a difference. And so I would like to really push on that as we move forward. It's just so easy to admire the problem. It's really hard to solve it, but we really need to solve it. Okay, so what can we do? So Sharice Sankar, who's in the Office of Pain Policy and Planning, has been working in this space in the pain area for a long time, and she just presented to the Pain Heal Multi-Work Council Working Group that Alan Bassbaum and Christine Wiesler are on. And so we were thinking we had to, address this topic. And so I was really taken by Sharice's pyramid scheme. Pyramid, not really a scheme, skeleton of how to think about this. So at the top is the biopsychosocial factors. So there may be genetic differences or environmental exposures that are going to change how the biology is playing out in a certain racial, ethnic, or socioeconomic group, and that could affect, how different populations perceive a condition, particularly like pain, or respond to a medicine, no matter what condition it is, or report what their problem is, particularly, say, in cognitive decline. There are certainly cultural differences in how this is understood and reported to doctors. And then there's likely bias going on in the assessment and treatment of different populations based on their racial, ethnic background. So research on how to kind of eliminate bias. I think there's a good time to do that. The socioeconomic factors are things that are very hard for NIH to turn around, but I wonder if there are research that could be done to kind of attenuate some of the health effects of these bad socioeconomic conditions. So one example was so certainly stress and anxiety and pain are really intimately connected. So to develop some kind of programs for stress relief, certainly in the pain space, is a potential research intervention that might be helped. And poor access to healthcare, again, something that NIH has a hard time with changing, but we could potentially do things like telehealth to reduce the cost of and improving the access of participating in one's health. So these are a couple of ideas of thoughts we had of interventions that could be proposed in research that actually goes after these improve health disparities. And I guess, just to sum up by saying that, these problems we've been dealing with for a long time, I think we all feel guilty that we haven't solved them. And that I've certainly been horrified when I hear the stories of racial bias that are reported to me from people in our institute. And, but, it seems like this is the time to do it. I mean, we should have done it a long time ago. No apologies. We should have done it a long time ago. But if we don't do it now, I don't think we're ever going to do it. So I think it's a great time to really think hard about how to make a big difference in this space. And we have good people here at NINDS, and so the council, please, let's get some discussion going, particularly suggestions on what do you think would be the most important avenues to travel down here.